Well, welcome again. We're happy to have the opportunity to welcome you to our program, and particularly, we're delighted today that we have an excellent guest professor. Dr. Anand has a long and extensive experience in pathology. He trained in pathology at the University of Oklahoma, where we first became acquainted, but prior to that, he received his MD and PhD. And then following his training initially in pathology, he also did a fellowship in hemopath at the Cleveland Clinic, and I think also SurgPath. Is that right, Anand?
Yes,
Yes.
Dr. Russell, yes.
And in addition, he's worked in a very high laboratory or high volume setting in laboratories overseas prior to joining us at the University of Oklahoma. So I'm looking forward to the challenging and unique cases that he will share with us this morning. And so from that, I'll turn the podium over to you, Anand, and let you go forward.
Thank you, Dr. Russell. Thanks for the kind introduction, and good morning or good evening for the audiences anywhere in the world. So let me start the screen share. So today I'm going to talk about some zebra cases that have come across during my practice here. And my goal is to actually help the pathologists on signing those zebra cases when they occur, like in how to sign those cases for practical purposes, and also help our clinician colleagues walk through the report so that they can manage the patients appropriately. So, all right. I hope you can see the screen.
Yes, you're good.
Yeah. Okay. Is it in a presentation mode, Dr. Russell, or is it showing?
Now it's in presentation mode.
Perfect. Okay. So as I said, so my goal for today is basically to help signing out some of the zebra cases. Some of them are straightforward histologically. Some of them are actually diagnostic dilemmas. So even if they are straightforward histologically, the cases that I chose have some issues in terms of staging and other clinically important decision-making criteria. So it's not moving. All right. So I have 5 to 6 cases depending on the time we have. So I would like to keep tight. So we'll try to finish by 8 a.m. Local time here. So as Dr. Hassel said, I did a fellowship in hematopathology. So that's my subspecialty of interest, as well as surgical pathology, in which I do GU pathology and breast pathology. So the cases I chose is a spectrum from pretty much all these 3 subspecialties. So I will show how to work them up based on the histomorphology that we see, when to seek help, and when I mean help, looking for other ancillary testings like molecular test, and even requesting expert consultation when you're stumped. And then how to navigate the world of ancillary tests and interpret those results in the context of what we have in terms of histology. And then finally, like based on all the results that we get, how do we put them together and help our clinician colleagues manage the patient based on the reports on these rare cases. So the first case I have is a 40-year-old female with a past medical history of breast cancer. She's status post mastectomy. So she's been routinely followed up for her breast cancer surveillance. And during a routine follow-up, she was noted to have a 2 cm renal mass. So it was a totally incidental finding, no clinical symptoms whatsoever. Just during the imaging, this renal mass was identified. So I'm going to stop the PowerPoint and share my screen to show you the H&E slides. Okay. So this one is, as I said, the patient has a history of breast cancer, but this incidental renal mass, which is representative of the entire lesion. So basically, it's clear there. Gonna go on full screen mode. There you go. So here's your native kidney, and this is the interface between this lesion, which is very well circumscribed at the edges. So you can see a sharp demarcation between the normal kidney and this lesional area. There is no capsule, so it is an unencapsulated, well circumscribed lesion. And then if you go on low power, you see that there are a lot of empty spaces with what looks like maybe vascular channels with hemorrhage. So there's this thin strands of tumor cells, which are kind of creating these empty spaces with hemorrhage. And if you look at the histomorphology and cytomorphology of these tumor cells itself, they are relatively polygonal. They have a mostly round nucleus. There is some variability in size and the chromatin condensation, but overall, they appear to be a little bit bland. There's no prominent nucleoli, and there's not that many mitotic figures. If you hunt them down, you can find a few, but by far they are pretty rare. And then the cytoplasm of these cells have this little bit of pinkish hue. Again, nothing alarming in terms of cytomorphology. And then when you go back to the areas where it has those clearings and cystic spaces which are filled with blood, the thin strands of cells, tumor cells, look exactly same like those sheets of polygonal cells. So when I saw this case, I had multiple differentials in mind. So let me go low power here. Okay, so I was thinking of angiomyolipoma, the epithelioid variant, which can have this kind of vascular channels, and it can be lipid poor, which means you may not see that many fat components. So here you have a thick-walled vessel, which again can sometimes is seen in part of AML, angiomyolipoma. So that was my top working differential epithelioid type of angiomyolipoma. And then I was thinking some kind of renal cell neoplasm with oncocytic changes. I was thinking of a vascular tumor, like an angiosarcoma. There was no history of any radiation this patient got for her breast cancer, and moreover, this is not in skin or dermis. This was in a kidney. So even though angiosarcoma was in my differential, it was not at the top. It was more towards the middle or towards the bottom of my differential. So I did a bunch of workup. And so I started with PAX8 to see if it is renal origin. So it had a weird pattern. So if you look in low power, it looks like they're positive, but then when you go on high power, the tumor cells itself is mostly negative. And remember, PAX8 should be nuclear staining, whereas this staining is mostly negative in the tumor cells. And in some areas where it is positive, like you can see this patchy staining there around the nucleus. So this is actually a cytoplasmic PAX8 staining, which is kind of abnormal. And I read this as negative for PAX8. I also did the routine markers for renal cell carcinoma like CA9, CK7, both were negative. Pan-keratin, I wanted to see if it is some kind of epithelial neoplasm or not. And here we have a nice internal control, and the tumor is completely dead negative. So it was pan-cytokeratin negative. So because epithelial angiomyolipoma was in the top of my differential, I did also melanocytic markers like HMB45 and SOX10 and melanA. And unfortunately, all of them turned out to be mostly negative. So here's the HMB45. There may be some scant weak positive, but overall they were negative. And so was SOX10 and panmelanoma. So I started like, so the angiosarcoma, which was in my differential, although not at the top. So I did some endothelial cell markers, and this is CD34. As you can see, CD34 is diffusely positive in these lesional cells. But as we all know, CD34 is not a very specific marker for vascular cells. So I threw in additional markers that can help me confirm whether these are vascular in origin. So I did a CD31, which is supposed to be a little bit more specific. And this one is actually negative. So it is pretty much highlighting the vascular channels in between the tumor cells, but the tumor cells per se were negative for CD31. And I also did ERG, which is another marker which is specific for vascular origin. And that one was probably patchy positive. So then I started thinking maybe with this patchy ERG positivity and CD34 expression, could this be some kind of like a epithelioid hemangioendothelioma? So I did FLY1, that was negative. So at this point, many of the markers, so I expanded to other non-renal cell origin tumors. So I did a bunch of other stains, which I'm not going to show, but basically I did like hematolymphoid markers to see if there's some kind of weird hematolymphoid neoplasm. So those markers were negative. I also did smooth muscle markers. So SMA was negative, Desmin was negative. I did c-KIT because of the oncocytic things, the chromophobe or oncocytoma of RCC. So both were actually, the CD117 was also negative. So I was kind of stumped at this point. So I was thinking of some kind of a bland vascular tumor or some kind of tumor with vascular differentiation. So at this point, I didn't have any more markers to test. One differential that I had, although I've never seen a case, was this, could this be a so-called rarely described juxtraglomerular cell tumor? And to be honest, I came to that as a last differential based on ImmunoQuery, which is a software that we have subscription to, where we can plug in some of the markers that we get positivity for based on IHC, and it will show possible differentials. So as I was going through all the differentials, it did say a case report of juxtaglomerular cell tumor, which can have CD34 expression and negative for PAX8 and maybe positive for some muscle markers. So I wanted to see how to prove that, and the only way we could do that was by doing a immunohistochemical stain for renin, which is the hormone that is secreted by the juxtaglomerular cells. So we did not have it in-house, and because it is such a rarely described entity, I then sent this case to Mayo Clinic, who the geopathologists there, I talked with them, and they did have renin IHC, but not as a clinically validated marker. So they said they can do it offline and see if this was going to be positive. And so here's the oops, there you go. So this is the renin IHC that was done at Mayo Clinic. And as you can see, this is diffusely positive for the tumor cells, were diffusely positive for renin. So they also have a pathologist there who is doing a case study and case series on reninoma, as they're called, or the better term is juxtaglomerular cell tumor. He reviewed the morphology and he agreed that this is the same entity. Now, after we got this information, I got back to my clinical colleague and asked him if the patient had any history of hypertension. And there was no obvious like malignant hypertension kind of situation on this patient, but apparently she was receiving some antihypertensive medication. So we thought clinically this best fits as a juxtaglomerular cell tumor. So the additional clinical history that would have been helpful was the history of uncontrolled hypertension, which we did not get at the time of this specimen submission. So eventually this was signed out as a juxtaglomerular cell tumor renal, which is a rare tumor arising from smooth muscle cells of afferent arterioles in the glomeruli, the so-called JG apparatus, which secretes renin. And these tumors are usually seen in young adults, usually female, which fits the demographic of the patient that I presented. And it's frequently associated with hypertension. Although there are certain non-functioning JG cell tumor, which may be not having an associated increase in blood pressure. So most of the time it is functioning, so it secretes renin, and therefore you'll have an increase in blood pressure. You may see hypokalemia because renin will stimulate the angiotensin and aldosterone pathway, and therefore aldosterone will cause hypokalemia. But we did not find any of those additional abnormalities in this patient's laboratory. So laboratory findings. So eventually, this was not a typical reninoma. The so-called atypical reninoma was what this was, and this eventually the patient was treated when this lesion was taken out. It's an indolent tumor. There has been very rare metastatic reports from patients with this kind of tumor. So that's the first case. So one pearl on this particular entity is there is no specific histomorphology that will help us identify this entity. So as I discussed, the clinical history may be of help, like uncontrolled hypertension before surgery that drops back to normal right after surgery. But we rarely see this tumor, and so many a times the clinicians are not even thinking of this entity. So you basically have to exclude pretty much all the other entities that we can think of. And once everything is ruled out, you need to have this as a probable differential when you can't think of anything else, and try to see if we can do this IHCA to prove the diagnosis. Okay, so let's move on to case number 2. This case is more of a staging dilemma than diagnostic dilemma, and you'll see what I mean by that. So this is a 70-year-old female. She presented with a mass in the periurethral area on the posterior aspect of the urethra, right in between the urethra and anterior vaginal wall. So there was a tumor which was sitting smack in the middle of urethra and vagina. So the initial biopsy, which I don't have right now, did not, it showed the tumor that I'm going to show. And then the patient underwent cystectomy with anterior vaginal wall resection, and which is what I'm going to show you now. Okay, so I'm going to again switch back to image sharing. All right, so this one is the cystectomy specimen with anterior vaginal wall resection, and here's the histomorphology of this tumor. So as you can see, as I scroll through low power, the tumor is looking bluish, which means they are a little bit basaloid, and they also have this cystic spaces. In some areas, there's necrosis within the cystic spaces. And here is the surface of the anterior vaginal wall. So this is just like your squamous epithelium. Um, and if you look at this area, there's not significant dysplasia of any kind. So this is important, which eventually helped us clinch the site of origin. But the tumor is kind of involving this mucosa. So this section, and I'll show another section where the tumor ulcerates the vaginal mucosa. And then if you go on the other side, and this is the section where you had the vaginal wall on one end, and on this side, you have the urethral lining with some periurethral ducts here. So the tumor is sitting, as it was clinically noted, right in between those two areas. And now if you look at the cytology of these cells, these look basaloid with some areas that shows peripheral palisading. So we were thinking of like, this is like a basaloid type of squamous cell carcinoma with some cystic degeneration. And if you look in the cells, they are showing some degree of pleomorphism, and there's prominent nucleoli and brisk mitosis that you can see here in this field. There's a couple of them. And it was more like a nested pattern of infiltration. It was not like single cell infiltration. So the question was, basically, this looked like a basaloid squamous cell carcinoma. So it was not a diagnostic challenge. But the question was, is this a tumor that is arising from the anterovaginal wall involving the urethra, or is it this an urethral tumor that is involving the anterovaginal wall? So the clinicians were saying that based on radiology, the tumor was centered right in between those two spots. So they were not sure, although they favored it to be urethral, but they could not be 100% sure. And here is again a section of the tumor sitting in between. This is the urethral surface. And as you can see here, you are starting to see the dysplastic changes in this urethral lining. And if you go back to the other side, which is where we had the vaginal epithelium, this is also squamous, but this one does not show any of those dysplastic changes. So why is this important? Why do we care whether this is arising from urethra involving anterovaginal wall or tumor arising from anterovaginal wall involving the urethra? So the answer is basically staging. So an urethral tumor that involves the anterovaginal wall, according to the AJCC 8th edition, should be staged as PT3, whereas a vaginal tumor that extends to the urethral/bladder mucosa would be considered PT4. The treatment, although, is pretty much similar, chemo plus radiation, but the clinical colleagues wanted to know where this tumor was arising. So the pathology was we could help them out saying that this was an urethral tumor involving the anterovaginal wall based on the subtle changes that I showed you. The vaginal mucosa, although it was involved by tumor focally, with the tumor ulcerating the mucosa, wherever we looked at the vaginal mucosa, the sections that I put in did not show any dysplasia. Whereas the urethral surface had the dysplasia, and the tumor cells were also found in the periurethral ducts. So this was more in keeping with a primary urethral tumor with squamous cell differentiation extending into the vaginal wall. So I did some stains. I did a P16 immunohistochemical stain and P53 IHC as well. So P53 was a wild type pattern, and P16 was negative. So that again helped me support urethral origin, because vaginal tumors are usually HPV related, and therefore you would see some kind of P16 expression. So this was completely negative. So I eventually favored this as a urethral tumor extending into the intervaginal wall. And it was staged as a PT3, and the patient received a chemoradiation with cisplatin-based therapy for this urethral tumor, and radiation of this field for treatment. Now, the third case is actually a very interesting case that I just signed out a couple of weeks ago. This was actually, it came as a consult. So this is a 60-year-old male who underwent aortic valve repair. So no clinical history of any other nature that we were provided with. So the only thing was, it was a valve that was submitted for routine pathology because he underwent the valve repair. So let me jump back to screen sharing on the image. All right. Okay, so this was the aortic valves tissue that was submitted. So as you can see, you have this kind of fibrous tissue. I'll go back to the dotted areas later. You have this fibrous tissue with dystrophic calcification. So this looked like valvular tissue. And within this valvular tissue, there are foci like here where we saw stuff like this, which is pretty pleomorphic, ugly looking cells. This was completely an incidental finding. They did not go after any lesion. So it was just noted on this aortic valve when it was submitted for routine pathology. So you have these foci where there's this fibrin/acellular material, maybe some hemorrhage. And then there are some foci where some necrosis as well. Again, you have like this kind of acellular fibrinous material. And then these cells, which cytologically looks very scary, that was present in this tissue. So initially, I mean, no history of any kind was provided. So reached out to the clinical team to see if they had any known history of any cancer. And the answer was negative. So this was the only finding, like an incidental finding. So when we got this case, so we worked up from an unknown primary. We thought of like all the differentials under the sun. Could be like an epithelial neoplasm, like a metastatic carcinoma of unknown primary involving the aortic valve. It could be a metastatic melanoma. It could be a hematolymphoid neoplasm. It could be some kind of a sarcoma involving the soft tissue. So every differential was under the sun, and I did the markers for epithelial cells. So pancytokeratin was negative, CK720 was negative, and also did the melanoma markers that were negative. And eventually we moved to hematolymphoid markers. So here is some of the hematolymphoid markers, which is CD45. I started with CD45, and we have CD45 in this focus, which is, as you can see, clearly diffusely positive. So this helped us land on at least which differential that we should be thinking of. So CD45 being positive, so I expanded them to other hematolymphoid markers, so CD3, CD5, CD10, CD20, and so forth. So I'll show you the main markers that were positive. So this is CD20. As you can see, all these large atypical cells are diffusely positive for CD20. It was negative for CD3. It was negative for CD5. It was positive for CD19, which is another B cell marker. So currently we have two B cell markers that are positive, CD19 and 20. And then with the morphology that we saw, which was pretty much large cells. Again, let me show you the morphology again. So pleomorphic large cells with a lot of apoptosis and mitotic figures. Oops, sorry. We were in the large B-cell lymphoma category. The differential was a large B-cell lymphoma. So I did the Hans algorithm workup. So I did CD10, BCL6, and MUM1. So this tumor cells were CD10 was negative, but BCL6 was positive and MUM1 was negative. So this was kind of a general central origin for large B-cell lymphoma. And it was negative for cyclin D1 and Ki67, which is a marker of proliferation, was pretty high. You can see it's pretty much close to 90%. So I mean, morphologically, we saw a lot of mitotic figures in apoptosis. So this is not a surprise. So high Ki67, large B-cell lymphoma. And then so I did EBV, which is a marker for, so I did an in situ hybridization for EBV, which we pretty much do it in all large B-cell lymphomas. And as you can see, let me get a good spot. Can see EBV positivity in these tumor cells. So it is subset patchy positive in those large cells. So this is the workup that we did. So it is EBV positive, large B-cell lymphoma. So the differential at that point was a diffuse large B-cell lymphoma with EBV expression. So that is a separate WHO entity, which is EBV positive diffuse large B-cell lymphoma. Or is this some kind of a diffuse large B-cell lymphoma that is associated with chronic inflammation? Or there was a recently described, recent as in within the past 5 to 10 years, an entity called Fibrin-associated large B-cell lymphoma. So these were the major differentials. Any of these could be EBV positive, but when you see EBV positivity, we try to put them as a separate entity because the prognosis is different and it's associated with a poorer outcome. But the last diagnosis that I have here, the fibrin-associated large B-cell lymphoma, this has been currently and the new edition of WHO that is in press currently for the 5th edition of hematolymphoid neoplasms. This particular entity has been separated out as a unique line diagnosis, fibrin-associated large B-cell lymphoma. So this entity, which was previously clubbed with the DLBCL associated with chronic inflammation, has been separated out because this is an indolent tumor, which is instantly found. They are associated with fibrinous material or amorphous material like our case. And these large cells are also EBV positive. They're usually non-GC subtype by Hans algorithm, but this case is actually GC subtype. But the most important thing for us to make this diagnosis, fibrin-associated large B-cell lymphoma, is we should rule out a systemic disease. So as soon as I got this large B-cell lymphoma, so obviously I called the oncologist and asked them again if there was any reported history of lymphadenopathy, any splenomegaly, any large, any B cells, B symptoms like weight loss, fever, night sweats, and so forth. And the answer for everything was no, negative, and nothing that they can think of. So the patient was having issues related to his cardiac status because of his aortic valve, for which he underwent this repair. But other than that, there was nothing significant. So given that clinical information and the finding that we have, which is a tumor that is localized to this aortic valve, which was found incidentally with association in the fibrinous areas, um, uh, I favored it as a fibrin-associated large B-cell lymphoma. And it is important because it has excellent prognosis. The surgical resection, which in this case, the aortic valve that was excised, is usually curative. And the patient does not need R-CHOP or other chemotherapy. You just need to follow this patient up. And this is important because unlike the other differentials that we have, the EBV-associated large B-cell lymphomas and large B-cell lymphomas associated with chronic inflammation, these patients do very well. They do not progress to involve systemic like lymph nodes or spleen or any other organs. So that's why this new entity was created in the WHO 5th edition, because the other differentials, the DLBCL associated with chronic inflammation that is usually seen in older group, is it causes a symptomatic mass. And when you look at the architecture, it can efface the tissue in which it is arising, and that's associated with high mortality rate. Also, the EBV positive diffuse large B-cell lymphoma is also an aggressive disease. So the two major differentials for this particular fibrin-associated large B-cell lymphoma both have a very aggressive disease course with poor prognosis, and so they end up needing chemotherapy, whereas this entity, fibrin-associated large B-cell lymphoma, does not need them. So we need to keep this differential now under the radar when we get a case where it is an incidental finding, where the biopsy or excision was done for something else and you end up finding this. So when you come across this, please try to keep this as a differential and work closely with the clinical colleagues to make sure there's no systemic involvement before you render this diagnosis. And then the next case is actually a 65-year-old male who presented with neurologic symptoms with a working clinical diagnosis of a demyelinating disease. So therapy was initiated for that demyelinating disease. There was no improvement in symptoms, and eventually they did a non-targeted biopsy because the radiology did not identify any focal lesions in the brain. It was a diffuse T2 flare involvement. So the biopsy was done, and I'm going to show you that first biopsy quickly. All right. So this biopsy was done for the demyelinating symptoms, and this is the biopsy from right parietal lobe. And what we have is a brain parenchyma, which shows gliosis. I'm not a neuropath expert, so I'm not going to show you a neuropath case. So obviously I do breast, GU, and heme. So it's going to be one of those three that I'm sharing. So the brain parenchyma shows gliosis, and there was a focus which has this clear cells. And when you look on high power, they look like histiocytes. They have this bubbly cytoplasm, very bland appearing nucleus. So this was consistent with histiocytes, and we did markers like CD68 was diffusely positive in this lesion. So the only thing that we found was a macrophage-rich white matter lesion, and that is a non-specific entity. It doesn't mean anything. It could be suggestive of an demyelinating disorder, inflammatory demyelinating disorder. if this was representative of what the patient was having. But otherwise, the report was pretty much non-specific. So the patient was continued being treated for demyelinating disease, and unfortunately, the patient started progressing rapidly, and the patient deteriorated to an extent that he was not able to walk anymore. He was also he lost his speech. So it was, and all this happened within 4 to 5 months after the biopsy that I showed. So it was rapid progression. So again, they went for radiology. They again did not have a targetable lesion. So they went for another biopsy. This time they took multiple pieces because the previous biopsy was pretty non-specific. So this is the second biopsy that was taken 6 months after the first one. And I'm showing you some areas where there's this perivascular small lymphoid cells with some neutrophils even coming out of the blood vessels. I'm sorry, I forgot to share the. Okay, hope you can see it. So there's this perivascular small lymphocytes and some neutrophils in the blood vessel. And then when you come across the brain parenchyma itself, this looks more busy than the previous brain parenchyma. You still have some areas where there are those glial cells, which are prominent, but this time you have, it looks like a infiltrating small to intermediate size cells. The differential at this point in this one was pretty wide. We did not know if this was some kind of a glial neoplasm, or is this some kind of a lymphoid cells, or is this some kind of metastatic carcinoma, like in a diffuse pattern, like a carcinomatosis cerebri pattern, or is this any metastatic melanoma, which can sometimes present with no history. So a bunch of stains were done. So again, I'm going to go straight to the positive markers. So it was negative for pan-CK, it was negative for melanocytic markers, it was negative for glial markers, those single cells. But then CD20, which is a B cell marker, highlighted those cells. This was interesting because usually the CNS lymphomas tend to form a mass, which you can see by radiology. This patient did not have such a mass. Patient had like a diffuse involvement of the brain parenchyma, and you can see why. Even in this biopsy, you see the CD20 cells that are going around the entire parenchyma. It is slightly accentuated around the blood vessels, but most of the cells are taking a stroll in the parenchyma. So CD20 was positive in those cells that were in the parenchyma, and these cells are, slightly intermediate in size. It was not obvious large cells, but it was more like an intermediate size cells. So I did the whole large B cell lymphoma workup, and this was negative for CD10. It was positive for BCL6. MUM1 was negative. MUM1 was positive in this case. So we were thinking of large B cell lymphoma, but the pattern was pretty odd. And then flow cytometry was not done because lymphoma was not in the differential. So I did not have any way to confirm the clonality of these cells by flow cytometry. So therefore, I ended up sending this for a molecular testing. So I sent for 2 molecular tests, basically. One was the molecular test to assess for gene rearrangement for immunoglobulin heavy chain, which, if positive, supports but does not clinch the diagnosis of a lymphoma. Because if you remember, this patient has been getting treated for a demyelinating disease, so he got some immunosuppressive drugs as well. So an infectious etiology, which leads to this kind of large cells in the brain, can cause this picture. and can also have what we call a pseudoclonality. So immunoglobulin gene rearrangement can support, but it is not going to help us make the final diagnosis. But I also ordered the second molecular test, which was a MyD88 mutation studies. MyD88 is a gene, the L265P locus mutation of that MyD88 gene, if positive, will support a diagnosis of a primary CNS lymphoma, because MyD88 mutations can be seen in primary lymphomas arising in immunoprivileged sites like brain or testes or breast. So I was hoping that one or if not both are going to be positive, so it would make my life easier to sign this case out. And luckily, this case did turn out positive for immunoglobulin gene heavy chain rearrangement as well as MyD88. So this was signed out as a primary CNS lymphoma. So let me share the screen. There you go. Okay, so the immunoglobulin gene rearrangement and MyD88 L265P mutation studies both came back positive, and therefore this was signed out as a primary CNS lymphoma, the so-called rarely described lymphomatosis cerebri type, where you do not have a definite mass-forming lesion, but it was involving the entire brain parenchyma. Shortly after this diagnosis, patient was started on chemotherapy, and the patient started improving significantly after the second cycle of chemotherapy compared to how the patient was before starting the chemo. So this is a rarely described form of a primary CNS lymphoma, and the way the cells were infiltrating was unique. And I went back to that original biopsy that was done 6 months ago, and CD20 was done even on that biopsy, but it did not show these cells. So we still do not know if that previous biopsy was representative of what the patient was undergoing, or if the lesion was still developing in that biopsy that we were not able to detect. But eventually this biopsy was clenching for this diagnosis. All right, I think we're right on time. I thought I might be able to go. Dr. Hassel, is it okay to go a little over? I do not know if not, we can stop here and take question.
I think it'd be great if you wanted to do this last case. That'd be great.
Okay, perfect. Sorry, I because of switching back and forth between two screens, it took longer than expected, and I apologize for that. So the last case I have is a pitfall case where we may be misled by what we're seeing. So this is a 30-year-old pregnant female who presented with a mass in the axillary tail of the breast during routine mammogram. The BI-RADS score was called 4B. No other history was available, and because it was routine mammogram, a patient was not seen by clinical team for this biopsy, but rather the radiologist was the one who was doing the biopsy. So we have so I received the biopsy of this axillary tail mass, and I wish there was an easy way to share quickly. Okay, so this was fragments of tissue that we received from this biopsy. So one thing that was clearly standing out were these squamous, keratinizing squamous epithelium with the associated tumor cells. And then we had the stroma where we had what looks like an infiltrative pattern of cells with some kind of desmoplasia. And the whole biopsy was fragmented. There was the two things that caught my eye in this was, one was these obvious keratinizing uh, squamous epithelium, and two was there was no breast tissue. It's pretty much a fibroadipose tissue. So I was not sure what was going on, where the localization was. Uh, I asked them, is this under the dermis? Because I saw like this area here, there were some adnexal structures, but there was no epidermis in this biopsy either. So we have these fragments where, again, you can see this kind of infiltrative appearing cells. But when you look at the cytology, they look relatively okay. They were bland looking. There's some degree of ATPR, not significant. And then if you look at these cells, which are associated with the keratin, they look again more basaloid. So I called the radiologist and asked them, hey, where is this located? Is there any skin lesion associated with it? And there was no clear answer. They said, no, it was just a mass in the axillary tail. And then I asked her, as the radiologist, the patient had any other breast lesions that they could see. They said, no, they could not see any breast lesion by ultrasound. And they said that does not exclude that there's no mass. There might be some a non-mass forming enhancements, but because of the pregnancy status, they said they couldn't do any other additional testing. So I ended up signing this out as invasive tumor because of this infiltrative pattern with associated keratinizing squamous fragments. And I gave it as a differential. I gave, in the comment, I gave two differentials. One was, I didn't focus on this part, but I'll show you now. If you look at this keratinizing squamous epithelium, there are some areas where there's like what we call as ghost cells, where there's empty lacunar spots with no nucleus. So I was thinking of some kind of adnexal tumor like a pilomatrixoma, but then I asked the clinical history, which the patient apparently did not have any obvious skin lesion. The other major differential was, is there some kind of a metaplastic carcinoma of a breast, which can have all these kind of features? So immunohistochemical stains is not going to help us because there's going to be overlap of any markers that you do. So it is mostly based on morphology. And because I couldn't get additional information and because they couldn't do additional radiologic studies, I left it as a differential. Favoring, I mean, I didn't favor one over the other. I just said it could be some kind of skin adnexal tumor, or if it is from breast primary, then this could be a metaplastic carcinoma with keratinizing squamous differentiation arising in the accessory breast tissue and axillary tail. So because of the special status that the patient was pregnant, the clinical team, without reaching out to us, decided to send this to molecular studies. So there are some molecular studies which can look at the gene expression profile of the tumor cells, and they can place the cell of origin based on the expression profile of those cells. And this was sent to one such molecular study, and that result came back as squamous cell carcinoma. So the clinical team was worried that this is squamous cell carcinoma. And remember, metaplastic carcinoma can also have squamous cell carcinoma profile because it can completely become metaplastic to squamous cells. Or it could be a squamous cell carcinoma of the skin/adnexal region, which can also have the same features. So they decided to go for a wide local excision at that point because they were not sure what to take out. And they wanted to just take out this area around the axillary tail. And then after she delivers the baby, they wanted to see if they can do additional studies and see if the patient needs any additional workup like surgery like mastectomy. So the skin excision and the axillary tail was taken out. And I don't have a picture of that, but essentially, on the resection specimen, we could see that this was kind of extending focally to the epidermis, and this was entirely based out of dermis. So based on the resection specimen, we were able to confirm that this is actually an adnexal tumor, not like a metaplastic carcinoma of the breast. And it was the pseudo-infiltrative pattern, which I showed you on the biopsy, was appreciated better in the resection specimen, and it was not actually a infiltration, but it's a pseudo-infiltration pattern. So this was signed out as a combined pilomatricoma and adnexal tumor consistent with the cutaneous mixed tumor. And because of the challenge, I also got an expert consult, and they agreed that this is actually a cutaneous tumor, not a metaplastic carcinoma of the breast. So the learning point or teaching point here is the molecular test, which was ordered here on this case, led the clinical team to believe that this patient was actually having squamous cell carcinoma, because the gene expression profile of this tumor is going to be same as squamous cell carcinoma. So without providing the context where what is the history, what is the location, how does that look morphologically, whether there is actual invasive tumor, the molecular test can be misinterpreted. And luckily, like because of the pregnancy status, the patient did not go any other significant surgeries. It was just a local excision, which is basically the treatment for the cutaneous adnexal tumor. So she was basically treated for this after the excision. So that's all I have. This interesting case was more of a pitfall than diagnostic challenge. I'd be happy to take if there's any questions.
Those are wonderful cases with very high value teaching points, and I really appreciate those. You've taught me certainly several things. I think it underscores the fact that we really are not in this alone, that we have to engage a network of help in whatever we do. Having a broad background such as you do is very, very helpful. But even then, we're still going to need more assistance to finally nail things down. And I think also, especially that last case, underscores how, the clinicians, if they don't include us in their network, that they can waste a lot of money and end up with some potentially misleading information. So this has been very, very helpful. Jami, do you have any questions for us? I think she's in Vietnam, but I don't see that she's going to likely ask us any questions today. So if people have questions, they certainly are free to comment in the comments or send questions directly to us, and we can get back to those on those questions. So thank you so much, Anand, for doing this morning. It's been a great session, and we'll look forward to doing it again sometime.
Thank you, Dr. Russell. Thanks for the opportunity. And I think if you have any questions, I would be happy to answer in the comments once we get it in the YouTube channel.
All right.
Thank you.
Have a good day.
You too. Bye-bye.